Assalamu alaikum. Good morning, everyone. Good afternoon, everyone. So today we'll continue our academic activity. We're starting with the pacemaker and defibrillator therapy in a cardiac surgery presented by Dr. Abdul Damir. Assalamu alaikum. Good morning. Then we'll continue with the short-term mechanical support by Dr. Abdullah Al-Qahtani, and we'll have our journal club, the Freedom Trial by Dr. Fatima Al-Hijab. We'll start after 5 minutes, inshallah. Assalamu alaikum. Good afternoon, everyone. So I'm going to talk about the pacemaker and the defibrillator therapy in the cardiac surgeries. So we're starting, we'll say, who's the patient at risk to develop heart block post-op? Patient who post-aortic valve replacement, mitral valve replacement, and tricuspid valve repair, which is the repairs of the valves. VSD patient, which was the anatomical of the conduction system is misplaced. HOCM patient, poor myocardial protection, and injuries to the blood supply to the blood supplying of the conduction system, and in infective endocarditis, which the valve and the conduction system will be infected. So the type of the AV block, we know that the first degree, which had the prolonged PR interval. The second degree, we have the Mobitz type 1 and the Mobitz type 2. The third degree block is complete AV discontinuity. So what are the causes of the AV block? Ischemia, iatrogenic ablation, infective endocarditis, Lyme disease, degeneration, and post-surgical aortic valve, mitral valve, or tricuspid valve repair. Congenital and instantly patient, and cardiomyopathy patient. So what is the cause of the SA node dysfunction? Usually in coronary artery disease, and cardiomyopathy, and reflex abnormalities, which carotid sinus hypersensitivity, vasovagal syncope. So what's the recommendation for permanent pacing in SA dysfunction? SA node dysfunction. In the American Heart Association guidelines, class 1 indication if to implant a pacemaker in a patient with sinus node dysfunction, documented symptomatic bradycardia, which including the frequent sinus pulse that product symptoms. And in a patient who is symptomatic chronotopic incompetency, and in a permanent pacemaker indication for symptomatic sinus bradycardia that result from required drug therapy for medical condition. In class 2A, permanent pacemaker implantation is reasonable with heart rate less than 40 when a clear association between the significant symptoms consisted with and actual presence of the bradycardia has not been documented. And in permanent pacemaker is reasonable for the syncope of unexplained origin when clinically significant abnormality of the sinus node dysfunction are discovered or provoked in the AP studies. In class 2B, the implantation of permanent pacemaker may consider in minimally symptomatic patient with chronic heart rate less than 40 while awake. And in class 3, which is not indicated in asymptomatic patient, and in a patient for whom symptoms suggestive of bradycardia have been clearly documented to occur in absence of the bradycardia, and in a patient with symptomatic bradycardia to a non-essential drug therapy. So what's the recommendation for the permanent pacing in acquired AV block? The third degree and advanced second degree AV block at any anatomical level associated with any of the one of the following condition: bradycardia with symptoms including heart failure, presumed to be due to AV block, arrhythmia, and other medical condition that require drug that result in symptomatic bradycardia, documented period of asystole greater than or equal to 3 seconds, or any escape rate less than 40 beats per minute in awake symptom-free patients. Or after catheter ablation for AV junction, post-operative AV block that's not expected to resolve after cardiac surgery, and neuromuscular diseases with AV block such as myotonic muscular dystrophy. Or in a second degree AV block, regardless of the site of the block with associated symptoms of bradycardia. In class 2A, asymptomatic third degree AV block at any anatomical site with average awake ventricular rate of 40 beat per minute, or faster, especially if cardiomegaly or left ventricle dysfunction is present. Asymptomatic type 2 second degree AV block with narrow QRS. Asymptomatic type 1 second degree at intra or infra-His level. First or second degree AV block with symptoms similar to those pacemaker syndromes. In class 2B, first degree block with more than 0.3 second in patient with left ventricle dysfunction and symptoms of congestive heart failure. In class 3, asymptomatic first degree block, asymptomatic type 1 second degree AV block at the supra-His. AV block expected to resolve or unlikely to reoccur, example, drug toxicity or during hypoxia and sleep apnea. And the recommendation for acute, for pacing after acute phase of myocardial infarction. In class 1, persistent second degree AV block in His Purkinje system with bilateral bundle branch block, or third degree AV block within or below the His Purkinje system after MI. Transient advanced second or degree infranodal AV block, and persistent symptomatic second or third degree AV block. In class 2B, persistent second or third degree AV block at the AV nodal level. And in class 3, transient AV block in the absence of intraventricular condition defect. And in transient AV block in the presence of isolated left anterior vascular block, acquired left anterior fascicular block in the absence of AV block, and in persistent first degree AV block in the presence of bundle branch block. And the recommendation of pacing in permanent pacing in hypersensitive carotid sinus syndrome in class 1 recurrent syncope caused by the carotid sinus stimulation, the minimal carotid sinus pressure induced ventricular asystole of more than 3 second duration in the absence of any medication. In HOCM, so the hypertrophic obstructive cardiomyopathy, the objective of permanent pacing in patients with HOCM is to improve outflow obstruction with early stimulating of the right ventricular apex. So the pacemaker is generally programmed to DDD mode. In some randomized studies showed that significant reduction in the LVOT pressure gradient with pacing and mild improvement in the functional status, and generally no improvement in the quality of life. The routine implantation of dual chamber pacemaker should not be advocated in all patients with symptomatic obstructive hypertrophic cardiomyopathy. So factors that in HOCM, if present, favor of pacemaker defibrillation. Those factors are personal history of syncope or sudden cardiac death, family history of sudden cardiac death, non-sustained ventricular tachycardia, massive hypertrophy if the wall thickening is 30 millimeter or more, and pathological drop in blood pressure with exercise. In HOCM, with exercising, the blood pressure will drop. So we see in the pacemaker box that there is 3 letters usually used. The first letter is what's the chamber pacing, and the second letter what's the sensing, and the third one was the algorithm pacing. So usually when we see fixed pacing, which is VOO, that's meaning we're pacing the ventricle without sensing and without algorithm. So just pacing the patient. And in AOO, which is the atrial pacing only, this is we're using in transplant patient. While the demanding pacing, which is VVI and AAI. VVI, which is pacing the ventricle and sensing the ventricle with inhibit. So we'll inhibit if we have set the pacing on let's say on 100. If it is above 100, will inhibit this beat. In VDD, which is pacing the ventricle and sensing both atrial and ventricle. In DD mode, which is pacing both ventricles, both ventricle and atrial, and sensing atrial and ventricle. While D is actually dual, inhibiting and triggering of the heart. So in dual pacing, pacing atrial and ventricle will increase the stroke volume 5 to 15%, which is the atrial kick. Pacing of the right ventricular apex will disrupt the normal sequence of activation because of the depolarization will spread more slowly over the ventricle than going through the conduction system. So an RVOT pacing may improve the stroke volume versus apical pacing because of favor effect on the activation sequence. And in biventricular pacing, in a patient with advanced cardiomyopathy will improve the left ventricular function by restoring the stimulus contraction of the septum and the free wall. In biventricular pacing in a patient with advanced cardiomyopathy, restoring the and the free wall. So, as we see here, the dual chamber pacing algorithm. We have in DD mode, which is pacemaker programming, including there is a lower rate and upper rate and EV delay. In atrial rate is between the upper and the lower rate limit. The pacemaker track the atrium to maintain one-to-one response between the right atrium and the right ventricle. If the atrial rate fall below or falls to or below the lower rate of the limit, then the atrium is paced at the lower rate. So if the atrial was, if we set the rate of the lower rate on 60 and the atrial fall down below the 60, then it will pace the atrial to the lower limit. And if the atrial rate exceeds the upper rate limit, the ventricular is paced at the upper rate limit with loss of the AP synchrony. And if the patient developed atrial fibrillation, the mode directly convert and switch to the VVI mode at the lower rate limit we set. So choice of the pacing technique, dual chamber pacing has become the standard of care, except in chronic arterial fibrillation. Dual chamber pacing may not be warranted in elderly patients, except when pacemaker syndrome, hypertension, or congestive heart failure is present. VVI pacing is appropriate for patients with bradycardia and chronic arterial fibrillation. AAI is useful for cardiac transplant with sinus arrest or sinus brady. So we're going to the epicardial versus endocardial lead. Epicardial lead are generally inferior to the endocardial in the electrical characteristic and are prone to conductor fracture. So epicardial pacing is more difficult at preoperative surgery. The epicardial approach is preferred in patients with congenital septal defect and single ventricle pathology, physiology, or mechanical tricuspid valve. In unipolar versus bipolar. So bipolar lead incorporate two isolated conductors. Unipolar system, a single conductor in the lead carries the negative current to the heart. The patient body is the conductor. And bipolar lead reduce the electrical noise over sensing and decrease the pacing of the diaphragm or chest wall. So what's the complication of pacemaker? Complication of the pacemaker mortality. It is a rare complication of the pacemaker implantation, which mostly by the lethal problem can include lead displacement, venous or cardiac perforation, air embolism, and VT or fibrillation. Lead displacement we said myocardial infarction and pneumothorax pacemaker syndrome, which we lose the AV synchrony, produce symptoms related to reflux effect or contraction of the atria against the closed AV valve, pacemaker dysfunction, infection, generator dysfunction, and undersensing or oversensing. So using the electrocautery in the surgery with the patient having a pacemaker. So unipolar pacemaker are more susceptible to electromagnetic interference than the bipolar unit. So an electromagnetic effect will include pacemaker oversensing, confusing the electromagnetic interference with the rapid heart rate. Then the pacemaker will reprogram after the surgery. Acceleration of impedance sensing the pacemaker to the upper rate limit, reversing to the backup mode or magnet mode. And so we're usually reprogramming the pacemaker to VOO or DOO, which is pacing the ventricle regardless of the sensing, or in VVT mode intraoperatively with the rate response to prevent the inhibit of the pacemaker acceleration. Magnet mode is a permanent magnet placed over the pacemaker, close a magnetic reed to switch and initiate the magnet mode in some pacemaker. Magnet mode is usually considered as a VOO to eliminate all the senses. So in a patient, an adult with congenital heart disease. So congenital heart disease may include the persistent left superior vena cava draining to the coronary sinus, which in this one, we are preferring to have a right subclavian approach, and a left superior vena cava may dislocate the subclavian vein, increasing the risk of subclavian vein puncture and a favor of cephalic cut down. So in positive fixation lead are useful for atrial pacing after mustard operation or Glenn, for pacing the smooth wall right ventricle in corrected transposition of the great arteries, and a coronary sinus lead can be provide ventricular pacing in Fontan patient, as there is no access for the venous system. In infant and children, so transvenous lead in children should include an intracardiac loop to allow for growth. Unipolar, a positive fixation lead are ideal use, usually fixing by insertion by cephalic cut down, subclavian or through subclavian vein, or through thoracotomy. In infant less than 6 months of age are suboptimal candidates for transvenous pacing because of the limited long-term lead utility. So then less than 6 years old, generator replacement in the subpectoral muscle will reduce the infection rate. In transplant recipient, the usual indication for pacemaker insertion in cardiac transplanted patient is the sinus bradycardia or sinus arrest, as we said before. So we'll manage by the AAI. If one-to-one ventricular response is observed with atrial pacing at 150, so if we pace at 150 and we have one-to-one ventricular response, this meaning there is no need for ventricular lead. So we'll talk about the ICD, the implantable cardiac defibrillators. The candidate for the ICD insertion for the secondary prevention therapy, patient who had VT or PF in the absence of acute MI. If EP study demonstrating inducible VT in a patient with non-sustained VT and with history of myocardial infarction. Myocardial infarction and left ventricular ejection fraction less than 30%. And primary prevention indication include ischemic cardiomyopathy with the left ventricular ejection fraction less or equal than 35 with NIHA class 2 or 3, less than 40 days post-MI, left ventricular ejection fraction less than 30% with NIHA class 1 with more than 40 days after MI also qualify for primary prevention. ICD is usually a bipolar lead for the ventricular pacing rate sensing and another to deliver the defibrillator current. So these are integrated into a single lead for endocardial insertion. So up to 30% of the ICD shock are inappropriate for the sinus tachycardia or other supraventricular tachyarrhythmia. Bipolar atrial lead can help to differentiate the supraventricular arrhythmia from VT. Most implants are just at the clavicle and in the abdominal location. The ICD contain high energy battery and capacitor that step up the output voltage to 600 to 800 volt at 35 to 40 joule. The recommendation for implantable Cardioverter-Defibrillators. Class 1 indication is ICD therapy is indicated in patients who are survivor of cardiac arrest due to ventricular fibrillation or hemodynamically unstable sustained VT after evaluation to define the cause of the event. It is indicated in patient with structural heart disease and spontaneous sustained VT. In a patient with syncope of undetermined the origin with clinically relevant, hemodynamically significant sustained VT. Patient with left ventricle ejection fraction less than 35% due to prior myocardial infarction, who are at least 40-day post myocardial infarction and NIHA class 2 to 3. Patient with non-ischemic dilated cardiomyopathy, who's having the left ejection fraction less than 35% and having NIHA class 2 or 3. With patient with left ventricular dysfunction due to prior MI, who are at least 40 days post myocardial infarction and having left ventricular ejection fraction less than 30%, and even with the NIHA functioning class 1. Patient with non-sustained VT due to prior myocardial infarction with ejection fractions less than 40% and inducible ventricular fibrillation or sustained VT at the AB study. In class 2A, ICD implantation is reasonable for the patient who had unexplained syncope with significant LV dysfunction and non-ischemic dilated cardiomyopathy, and in patient who sustained VT and normal or near normal ventricular function, in HOCM patient who have one or more major risk factor for sudden cardiac death, prevention of sudden cardiac death in patient with arrhythmogenic right ventricle dysplasia or cardiomyopathy who have one or more risk factor for sudden cardiac death. Reduce sudden cardiac death in patients with long QT syndrome who are experiencing syncope and or VT while receiving beta blockers, and in patient who non-hospitalized patient awaiting transplantation. And in class 2B, it is considerable in non-ischemic heart disease who have left ventricular ejection fraction less or equal 35 and having NIHA class 1. It's considerable in a patient with long QT syndrome and risk factor for sudden cardiac death, and in patient with a syncope and advanced structural heart disease who through invasive, non-invasive investigation have failed to define the cause. Familial cardiomyopathy associated with sudden death and LV non-compaction. And class 3, it's not indication for a patient who do not have a reasonable expectation of survival with acceptable functional status for at least 1 year, with increase with insistence of VT or ventricular fibrillation, with significant psychiatric illness that may be aggravated by device implantation, and in NIHA class 4 patient with a drug refractory congestive heart failure who are not candidate for cardiac transplant. In a syncope, in a patient with syncope of undetermined cause, in a patient without inducible ventricular tachyarrhythmia and without structural heart disease. With ventricular tachyarrhythmia due to completely reversible disorder in the absence of structural heart disease. ICD battery depletion. So the battery life in the ICD is now typically more than 60 months. The complications for the generator replacement will include infections, myocardial infarction, and death. The progression of heart failure and coronary artery disease will increase the risk of replacement of the battery. So in other complication that we'll face in the ICD lead dysfunction, it's about more than 50% of the ICD recipient have some lead revision at 10 years of follow-up. The problem will include lead fraction, high defibrillator threshold, oversensing and undersensing, as we said before. In the American Heart Association in cardiovascular implantation and electronic device infection, the incidence of device infection in long-term follow-up for a study that was conducted in a single center found that the infection rate was 3.5% in the abdominal and 0.5% with the pectoral. So the risk factor showed that the risk factor for infected ICD, having a patient with diabetic mellitus, patient with heart failure, patient who had reduced generator change, renal failure, patient with oral anticoagulation, immunosuppression patient, and the presence of more than 2 pacing lead. So this is the Staphylococcus species. It's the causing of the bulk of device infection and account for 60% to 80% of the cases in most reported series. Followed by the oxacillin sensitive Staph aureus, then gram-negative bacilli, and the recommendations for diagnosis of device infection and associated complication. In class 1, all patients should have at least 2 sets of blood culture drawn at the initial evaluation before combat initial of the antimicrobial therapy. Generator pocket tissue and the lead tip should be sent for culture and gram stain when the device was explanted. Patient with suspected device infection who either have positive blood culture or have a negative blood culture but have recent antimicrobial therapy before blood culture should undergo TEE for device infection or valvular endocarditis. All adult patients who are suspected to have a device-related endocarditis should undergo TEE to evaluate the left side heart valve, even if the transthoracic view had demonstrated clear adherent mass. The recommendation for removal of infected device in class 1, complete device and lead removal is recommended for all patients with definitive device infection as evidence by valvular or lead endocarditis or sepsis. Complete device and lead removal is recommended for all patients with device pocket infection as evidence by abscess formation. Complete device and lead removal is recommended for all patients with valvular endocarditis without definitive involvement of the lead. Complete device and lead removal is recommended for patients with with this one, I have some questions for you. So can someone read the question? So, if we which of the following? تفضل مرتضى.
Which of the following is not a class 1 indication for permanent pacemaker? Sinus node dysfunction with symptomatic bradycardia, AV block in symptom-free patient in atrial fibrillation with pauses more than 5 seconds, asymptomatic
LAFB, which is left atrial and block and
vesicular left vesicular block and first degree AV block, third degree AV block that results from required drug therapy for myocardial, for medical conditions, alternating left bundle branch block and left bundle branch block. Not the class 1. I would say C.
Yes. So all of them is a class 1 indication for permanent pacemaker except C. So all of the following statement about device programming are true except DDI mode will trigger the ventricular depolarization on basis of atrial activity. B, patient with pacemaker who are pacemaker dependent should be programmed asynchronously before the surgery. C, potential interaction between the device and electromagnetic field include inability of the device to deliver pacing or shock, lead tissue in interference damage, changing the pacing behavior, will reset the backup mode, or inappropriate implantable Cardioverter-Defibrillators therapy. D, electromagnetic interfere has been reported with TNS unit. Mode switch usually occur in the setting of the atrial tachyarrhythmia and avoid ventricular tracking of rapid atrial beat. So the answer is A, the DDI mode will trigger the ventricular depolarization. No, the DDI will inhibit the ventricular depolarization. So thank you. And this is my references. Any questions? Thank you, everyone. We'll have a break for 10 minutes, then we'll be back, inshallah.
Thank you.
دكتور عبد الله تفضل. تسمعني دكتور؟ ما في صوت.
الو تسمعوني يا عبد الملك؟ Can you hear me؟
اي تفضل، تو تبدا من اول لو سمحت.
اي ابشر. السلام عليكم. I am عبد الله القحطاني, surgery from King Fahd Cardiac Center, KKUH. Today I'm going to present short-term mechanical support in cardiac surgery, inshallah. Introduction: short-term circulatory support are designed to be used for a wide range of conditions, ranging from prophylactic to management of cardiogenic shock, acute decompensated heart failure, or arrest. Patients in cardiogenic shock require early aggressive therapy to restore a normal cardiac output and maintain an end organ perfusion. So tissues, time is tissue, sorry. So this is about cardiogenic shock. It's in 2 to 12% of patients after acute MI. Post-cardiotomy period in the range of 0.2 to 0.6%. Acute decompensation in chronic heart failure patients. Severe cases of myocarditis and postpartum cardiomyopathy. So each device improves the following parameters of circulatory function with some variations. End organ perfusion, reduction in intracardiac filling pressures, reduction in left ventricular volume, wall stress or oxygen consumption, augmentation of coronary perfusion, which is will be explained in next slides, inshallah. So 4 major categories of circulatory assist devices. The balloon pump, non-intra-aortic balloon pump, percutaneous mechanical circulatory assist devices, ECMO, and non-percutaneous centrifugal pumps, which are used for bypass, cardiopulmonary bypass machine. So we'll start with the balloon pump, intra-aortic balloon pump. Guidelines, American Heart Guidelines on ST elevation MI made the following recommendations for the use of the balloon pump in the following settings. Cardiogenic shock that is not quickly reversed with the medical therapy. Routine use of balloon in cardiogenic shock is a class 3 recommendations. And in 2016, European Society of Cardiology Guidelines for treatment of acute and chronic heart failure. Also in acute mitral regurg, particularly due to papillary muscle rupture or ventricular septal rupture. European Society of Cardiology for ST elevation MI segment suggests the balloon can be used for stabilization of patients with these conditions. So history, the balloon often the first line for mechanical assistance, which is used in 1968 by Cardioverter, reported survival of 1 of 3 patients with post-infarction cardiogenic shock refractory to medical therapy using the intra-aortic balloon pump. So this is the machine, as you see here, which works by 2 mechanisms during systole and diastole. During systole, deflation, which decreases the afterload, which is the main physiological part for this support, and diastole, which is inflation during this part. I think there is mistake here. So during the systolic inflation, augmentation of the systolic pressure increase the coronary perfusion. So concepts, two concepts, systolic unloading and diastolic augmentation. So this diagram is explaining the mechanism of action of the intra-aortic balloon pump, which is reduce the myocardial oxygen demand during the systole and increase the perfusion of the coronary arteries during the diastole. So physiology. The major physiological effect of the balloon pump are, first, reduction in LV after load, reduce the peak systolic wall stress by 14 to 19%, reduction in the LV systolic wall tension and oxygen consumption, also increase in coronary perfusion pressure, so the coronary flow velocity increases by 87%. Diastolic augmentation. Patients, we have patients factor, the balloon catheter factors and intra-aortic balloon pump itself factors. Patient factors, heart rate, the mean pressure, stroke volume, and systemic vascular resistance. The catheter sheath, unfolded position, intra-aortic balloon pump catheter, if there is leak or no, the hilum concentration. The balloon pump itself, the timing, which is, I'm going to talk about the early mistakes or errors, about timing of the balloon pump, position of the intra-aortic balloon pump, augmentation control. So how to check the waveform is acceptable or not? First, change it's from 1 to 1 to 1 to 2 augmentation. Check the dichrotic notch, which is here. Early before the first augmentation cycle of the intra-aortic balloon pump. See if the augmentation starts at the point. This should produce a sharp V inflation, as you see here. It's become after the peak systolic pressure. So the inflation is coming here. So peak diastolic pressure, which is augmented by the balloon. So check if the diastolic augmented wave is greater than systolic wave. So this is the systolic wave, the native heart systolic wave, and this is the peak diastolic augmented pressure, which is greater than the native systolic pressure, which is good sign for the balloon pump. So confirm if end diastolic wave following the augmented wave is less than the non-augmented wave, as you see here. So balloon aortic in diastolic pressure wave will be less than the non-augmented one, which is the new cycle here, as you see. So about errors, so we'll start with early inflation, which is the inflation of the balloon prior to aortic valve closure. So the characteristics is inflation of the balloon prior to the dichrotic notch, so it's early. And diastolic augmentation encroaches into systole, may be unable to distinguish. So this is difficult to distinguish through this diagram. Physiological effects, potential premature closure of aortic valve, increase the left ventricular work, in diastolic volume, in diastolic pressure, and capillary wedge pressure, increase left ventricular wall stress and afterload, and also increase the myocardial oxygen demand and aortic regurgitation. So the other issue is late inflation. So inflation of the intra-aortic balloon pump markedly after closure of the aortic valve. So the characteristics are inflation of the balloon after the dichrotic notch, absence of the sharp V wave, so suboptimal diastolic augmentation, and so on, suboptimal coronary artery perfusion. So early deflation, which is the premature deflation of the balloon during the diastolic phase. So seen in sharp drop following diastolic augmentation, suboptimal diastolic augmentation, assisted aortic end diastolic pressure may be equal or less than an assisted aortic end diastolic pressure, or systolic pressure may raise. So physiological effects, suboptimal coronary perfusion, potential for retrograde coronary and carotid blood flow, angina may occur as a result of retrograde coronary blood flow, suboptimal afterload reduction, and increase the oxygen demand in this situation. Late deflation of the balloon during the diastolic phase. So the characteristics are, as you see here in the diagram, the aortic end diastolic pressure may be equal to the unsustained aortic end diastolic pressure. Rate of raise assisted systolic is prolonged. Diastolic augmentation may appear widened. So afterload reduction is essentially absent. This is the physiological effect. Increase myocardial oxygen demand and consumption may to the left ventricular ejection, ejecting against the greater resistance and a prolonged isovolumetric contraction. So maybe impede left ventricular ejection and increase the afterload. So indications for the balloon pump is cardiogenic shock, as we mentioned in the previous slides, after MI or mechanical complications of MI, MR or VSD, in association with CABG, patient with severe LV dysfunction, patient with intractable ischemic arrhythmias, or in association with non-surgical revascularization like high-risk coronary interventions, severe LV dysfunction with left main coronary artery disease, complex coronary artery diseases. The contraindications, which is aortic regurg, aortic dissection, or severe aortic and peripheral vascular atherosclerosis, which may cause making the debris coming up and making stroke or another ischemia all over the body. Techniques of insertion, usually inserted into the common femoral artery either by the percutaneous technique or surgical cut down. Catheter may be inserted in anticipation of the balloon pump use. So alternative, the iliac axillary arteries and abdominal aorta are infrequently used in patients with severe aortoiliac or femoral occlusive diseases. Placement of the balloon graft sewn into the subclavian artery is a strategy that has an advantage to allow the ambulation of the patients while waiting for the next stage of therapy. So this is the positioning. The end of the balloon should be just distal 1 to 2 centimeters to the takeoff of the left subclavian artery, as you see here in the two pictures below. So position should be confirmed by fluoroscopy or chest X-ray. So here the tip of the catheter, as you see here, it's before the aortic knob, after the aortic knob, sorry. Expected changes in hemodynamics profile during using the balloon pump is decreased in systolic blood pressure by 20%, increase the diastolic pressure 30%, increase the mean arterial pressure, reduction in heart rate and 20%, and the capillary wedge pressure by 20%, and elevation in the output by 20%. So timing, ECG, during ECG, inflation is set for the peak of the T wave at the end of systole, with deflation set just before or in the R wave, or the peak of the R wave. Arterial waveform inflation should occur at the diacritic notch, with deflation just before the onset of the aortic upstroke, as I will explain it in the next slide. As you see here, this is ECG signal, most common. Inflation, middle of T wave, as you see here. This is the arterial wave. So the inflation started at the middle of the T wave in the ECG. So this is the inflation during this diastole. So deflation, peak of R wave. So it is the same one here, but this is before, sorry. This is before the second wave. So you see the timing of deflation just at the peak of R wave as the systole is starting. So removal, percutaneous intra-aortic can be removed. The balloon pump can be removed without exposing the femoral puncture sites. The exit site is prepped and secured. Securing sutures are cut. The balloon catheter is disconnected from the pump and completely deflated using 50 ml syringe. And the proximal artery is compressed and retrograde bleeding is allowed with flushes any distal clot into the wound. So the distal femoral artery then is compressed and antegrade flushing then is allowed. Finally, steady non-occlusive pressure is held over puncture sites for about 30 minutes. So if the balloon is inserted via a cut down, fairly or preferable is removed in the OR for possible repair, and leg examination is a must. So complications, it's vary between 12 to 29%. So leg ischemia is the most common complication. Incidence about 9 to 25%. Balloon rupture and thrombosis within the balloon. Septicemia and infection at the site of insertion site. Bleeding, false aneurysm formation, and lymphostula or lymphocytes. So the pre-insertion status of the pedal pulses should be determined and recorded before the balloon is inserted in every patient. So result time of insertion affects hospital mortality, of course. Pre-operative insertion is associated with a mortality of 19%. Mortality intraoperative is increased to 32%, and post-operative insertion is increased to 40%. Prophylactic, not routine. So this is the guidelines. 2010 American Heart Association is the elevation of my guidelines listed specifically. The balloon used in cardiogenic shock as class 1B and 1C recommendations respectively. 2013, using of the mechanical circulatory support devices is reasonable in patients with STEMI who are hemodynamically unstable and requires urgent CABG. So it's class 2A recommendation. As you see here, this is the explanation of the 2018. It's almost the same. So this is a study of New England Journal of Medicine, 600 patients who presented with acute MI and cardiogenic shock, who were to be treated with the revascularization strategies. 300 patients received an balloon, and almost 300 other patients were treated medically. So there were no difference in the 30-day mortality between the balloon and the medical therapy, which was respectively 39.7% and 41.3%, and no difference in adverse events also. So we're going now to the direct circulatory support part. Ideal devices should be capable to provide adequate flow, maximize the hemodynamics, unload the left ventricle, fits all patients or all of all sizes, diminish risk of infection, and avoid the inflammatory response. Indications, the indication can be bridge to decision, or to bridge, or to transplantation. In terms of hemodynamics, if the cardiac index is less than 2.2 liters, systolic blood pressure less than 90, capillary wedge for more than 20, and with concomitant use of 2 inotropic agents. Devices currently approved by FDA, including the veno-arterial ECMO, Impella devices, thoracic Centrimag, thoracic paracordial VAD, and tandem heart system, which we are talking about each one apart. So ECMO, it's a direct extension of principle of the bypass machine. The system consists of the following: membrane oxygenator with integrated heat exchange system, centrifugal pump, heat exchanger, and circuitry interfaced between the patient and the system. So biocompatible heparin-pounded bypass circuits. So the pumps, they are basically 3 types: roller, impeller pump, and centrifugal pumps, as you see here in the picture. So this is the explanation about the ECMO machine. As you see here, it is there is the inflow and outflow. The inflow is from the right atrium as a venous return, and outflow is to the aortic ascending aorta for arterial cannulation as central ECMO. So ECMO principles: desaturated blood. Desaturated blood is drained through a venous cannula. CO2 is removed, oxygen added through the device. The blood is then returned to systemic circulation through another vein, so veno-venous ECMO or veno-arterial ECMO. So indications, there are many indications for ECMO. One of them is hypoxic respiratory failure, with a ratio of arterial oxygen tension to fraction of less than 100%, less than 100 millimeter mercury, despite optimization of the ventilator settings, hypercapnic respiratory failure type 2, with arterial pH less than 7.2, ventilatory support as a bridge to lung transplantation, cardiac circulatory failure, refractory cardiogenic shock, massive pulmonary embolism, cardiac arrest failure to wean from cardiopulmonary bypass after cardiac surgery, or as bridge to either cardiac or lung transplantation or placement of VAD devices. Technique. Cannulation is central, either central or peripheral cannulas. The central intraoperative with existing right atrial and aortic cannulas. Peripheral cannulation, surgical cut down, direct versus side graft or percutaneous insertion. So this is the arterial cannula of 16 to 20 French, and venous cannula of 18 to 25 French are used. Along venous cannula is directed to the right atrium under TE guidance. 8 to 10 French perfusion cannula can minimize limb ischemia using ECMO. Flows of 4 to 6 liters per minute are possible. So maintenance and monitoring during using the ECMO. Once respiratory and hemodynamic goals have been achieved, flow is maintained. Oximetry, pressure monitoring, including MAP, pre-pump pressure, pre and post-oxygenator pressure, vital parameters, heart rate, respiratory rate, temperature, flow rates, neurological status, vascular status to be monitored. And anticoagulation for sure with fractionated heparin infusion titrated, ACT of 180 to 200. Complications, bleeding, thromboembolism, heparin-induced thrombocytopenia, neurological complication or leg ischemia. So cannulation-related complication, vessel perforation with hemorrhage, arterial dissection, bleeding, distal ischemia in veno-arterial ECMO. Treatment, inserting of distal perfusion cannula in femoral artery, as you see in the picture, distal to ECMO cannula, so we can perfuse the distal part of the arterial cannulation. So the Harlequin syndrome or north-south syndrome, which is a saturation of upper part of the body is lower than that of the lower half. This is one of the complications of or incidental complication of ECMO. This is due to flow competition in the aorta, recovering heart versus ECMO pump, which is high cardiac output from native recovering heart prevents the retrograde flow of ECMO to perfuse upper part. If pulmonary function is impaired, so blue head, deoxygenated blood to upper part, and red legs, hyperoxygenated blood to lower part, as it's mentioned here in this picture as explanation of the Harlequin syndrome. So newer devices we're going to talk about briefly. The CardioHelp system. It's a compact ECMO system with a low priming volume and an integrated oxygenator, small size and good for transport, which is one of the advantages for using this device. Safely transporting patients with cardiogenic shock. After arrival at the accepting hospital, overall survival was 62%. I couldn't find the studies about this device yet. It's under process. If you see, this is the CardioHelp system. The tandem heart is a percutaneous ventricular assist. This is the second device. It's a percutaneous ventricular assist system. FDA approved for short-term, less than 6 hours used. Cannula are introduced from the femoral vessels by either percutaneous or direct insertion techniques. So cannula delivered across the atrial septum. Outflow typically is directed into the CFA, and position is facilitated and confirmed by fluoroscopy. Excellent left atrial decompensation. As you see here, this is the picture of the tandem heart through the septal to the left atrium. So it's going to drain the blood from the left atrium to the machine and vice versa. So this is the small, or I think it is the device itself. You see here. So most of the experiences has been in the cath lab to facilitate the high-risk PCI. Flows up to 4 liters are typical with surgical cannulas up to 8 liters. When placing a long-term VAD in a patient on tandem support is necessary to repair the atrial septum. ACT targets about 200, and right ventricular assist device configuration is also possible percutaneous and surgical. CentriMag pump is a centrifugal pump. It requires only a very small priming volume. It can be configured for both right and left-sided support, central cannulation through the median sternotomy, up to 10 liters of support can be achieved. So it has an FDA approval for 6 hours of use if it's used for left ventricular assist device or for 30 days as a temporary RVAD. As you see here, it can accommodate oxygenator within circuit to form full cardiopulmonary support, the LVAD and RVAD. So Levitronics CentriMag, as you see here in this picture. So Impella, it's a microaxial pump, both peripheral and central cannulation available. The pump is directed across the aortic valve into the left ventricle. The cannula portion of the device, which sits across the aortic valve with integrated motor. The small diameter of the cannula allow easy cohabitation of the aortic leaflets, resulting in minimal aortic insufficiency. As you see here, this is the Impella, which claims it's the world's smallest heart pump. Catheter has pressure transducer to each end, making it possible to measure pressures and adjust the device without additional imaging. This is very small. Okay. Deployed under fluoroscopy or echo guidance, and blood is aspirated through the distal tip inlet area from the left ventricle and pumped into the ascending aorta at the proximal tip outlet area of the catheter motor. So Impella types, we have 2.5 generators up to 2.5 liters per minute of flow and requires 12 French catheter. The other one generates up to 4 liters per minute of flow and requires 14 French catheter. Impella 5 generates up to 5 liters of flow, but requires 21 French catheter. Surgical cut down to the femoral artery, or more commonly insertion through a vascular graft sewn to the axillary artery is required. This is the device. As you see here, there is an inlet and outlet area. This is 11 French size and greater than 4 liters per minute. This is the LD type, which is blood inlet area, and the outlet with 21 French pump motor, and can flow rate up to 5 liters per minute. So in general, device selection, no data to recommend one device over another. Selection usually based on availability. Patients undergoing CPR are best served by urgent femoral cannulation, so to avoid delay of transportation and sternotomy. Patients with severe hypoxia and lung injury benefits from oxygenation and lung rest provided with ECMO. For post-cardiotomy support, typically patients are supported up to 48 to 72 hours while transplant evaluation is completed. So then they are translated to more long-term devices if myocardial recovery has failed, which is going to be presented next week in long-term mechanical support. Biventricular support is often required for fulminant myocarditis, also can be used. So patient management, ideally pump flow would achieve a mixed venous saturation of greater than 70%. Low flow status can often be corrected by intravascular volume expansion. With centrifugal pumps, speed can be adjusted to control flow and allow some cardiac ejection to decrease stasis and intracardiac thrombus formation. Excessive pump speed can also cause significant hemolysis. So fluid administration is the best way to increase the flow. However, right-sided heart failure also may manifest as a low flow state in the presence of low pulmonary artery pressure. Weaning. Trial is usually attempted after 48 to 72 hours of support. It's critical not to rush weaning and to allow time for myocardial as well as end-organ recovery. Flow is reduced gradually in increments of 0.5 to 1 liter per minute. Adequate anticoagulation is critical during this low flow. So in general, it is not recommended to reduce flow less than 2 liters per minute for a prolonged period to prevent the stasis or thrombus formation. Optimal medical therapy support or pharmacological support and continuous TEE evaluation of ventricular function is a must. So flows are reduced while monitoring blood pressure, cardiac index, pulmonary pressure, and the ventricular devices. Maintenance of cardiac index and low pulmonary pressure with preserved left ventricular function by echocardiography suggests that the weaning is likely. A failed attempt at weaning should result in resumption of full flow. So patients who are transplant candidates undergo for a full evaluation and subsequently are staged to a long-term ventricular assist device as a bridge to transplantation. So key points: recognize cardiogenic shock in the preoperative and postoperative patients. Have available at your institutions at least one of the available temporary support systems. Initiate the pharmacological and first-line mechanical support, the balloon pump in shock patients. Attempt to treat the causative issue. Recognize when these conservative methods fail and act quickly to implement direct cardiac support to restore adequate end-organ perfusion and decompress the heart. Initiate the discussions with the center at which advanced heart failure therapies, transplant, long-term BAD are possible. Stabilize the patient and initiate transfer to a tertiary center or definitive therapy weaning. So this is the end of my lecture. Thank you so much. I couldn't bring many questions out of this lecture. I will try to prepare it and send it to the question bank. Thank you so much.
So I have a question.
تفضل يا دكتور.
In your center, what's the preference if somebody is post-cardiotomy, you cannot wean him off bypass? What's your choices of support?
About if the patient trialed about attempts of weaning of cardiopulmonary bypass, I think we will recommend to start ECMO regarding my references.
So ECMO is your first choice?
Yes.
Okay. Do you see? Do you use intra-aortic balloon pump for surgical patients?
What do you mean, doctor?
Again, intra-aortic balloon pump can be indicated either preoperatively or immediately postoperatively for patients who are not doing well.
Yeah, yeah, actually, it's anticipation of patients. If we are thinking the patient would need intra-aortic balloon pump post-op for support, we will expose the access and insert the catheter. So in case we need to do intra-aortic balloon pump after the surgery, but if we, I think if we failed to wean the patient from the bypass, we might use the balloon pump first, okay? After that, I think that eventually we're using the ECMO machine.
So your first choice is intra-aortic balloon pump?
Yes.
Or ECMO?
No, intra-aortic balloon pump.
Okay. How many cases per year do you need intra-aortic balloon pump?
I am not the good person to ask this question, but about my experience last 6 months, we've been using the intra-aortic balloon pump maybe 3 times.
Okay. And how many patients out of those required ECMO?
2 of them.
Okay. And what's the survival rate of those 2 patients? Did they survive or did they succumb to their disease?
One of them survived. I just, if I can call, one survived, and other one he didn't come me.
Okay. Well, thank you very much. Thank you.
Thank you, Dr. Farid.
So, Dr. Farid, do you support going directly to ECMO rather than starting with the intra-aortic balloon pump? Dr. Farid?
Another seniors, just to answer the question. Interesting question.
Dr. Farid has some issue with his connection. So, Abdullah, what do you think? Abdullah Al-Hudayb.
Hello. Probably there are more seniors to answer this question, but I think intra-aortic balloon pump is much cheaper, less form of mechanical support, which has its indications. I don't believe it's lack of answer or right or wrong answer. Of course, more of support would be a balloon pump as an initial if it's indicated, especially with coronary artery disease. And to keep in mind ECMOs have downside, especially with ischemic myocardium, putting more, especially need to vent the left side. So using an ECMO might worsen the situation or worsen the condition of the myocardium. So it's, I believe it's complicated, but every mode of support has its advantages and disadvantages. But of course, the balloon pump is going to stay for a while in the practice, I believe. And even it's been used for bridging to transplants in some patients until the patient gets the donor. Some studies. Thank you.
Any more questions?
Okay, thank you, Abdullah.
يعطيك العافية.
We'll have another 10 minutes break and then we'll start with the journal club. Dr. Fatima?
Yes, doctor.
No, you can start. Thank you.
Okay. Okay. Hello, everyone. So now I'm going to talk about FREEDOM trial, which is the future revascularization evaluation and patients with diabetes mellitus, optimal management of multivessel disease trial. So as an introduction to the FREEDOM trial, revascularization for patients with multivessel coronary disease is performed commonly throughout the world, and over 25 to 30% of such patients have diabetes. In the PERI trial, the subgroup of diabetics with multivessel coronary disease who underwent CABG lived longer than those with PCI. The FREEDOM trial is the largest prospective study in diabetics with multivessel coronary disease, intensively treated medically and seeking to discover the best revascularization approach. So regarding the study design, the eligibility was for DM patients with multivessel coronary artery disease. They were randomized in a ratio of 1:1 into 2 different groups. The first one with multivessel stenting with drug-eluting, and the second one CABG with or without cardiopulmonary bypass. And those patients were intensively treated with medical therapy. So regarding the study design, it was a superiority trial of 7 years with a minimum of 2 years and a median of 3.8 years. Around 1,900 patients were involved in this study, and they were divided almost equally in the 2 groups. That involved patients from 131 centers from all around the world. The primary outcome was a composite of earliest occurring of all-cause mortality, non-fatal MI, and non-fatal stroke. The secondary outcomes were basically the MACE, which is a combination of death, myocardial infarction, stroke, repeat revascularization at first year, and at 30 days post-procedure. And the second most important secondary outcome was the cost effectiveness. So the diabetes mellitus was defined according to the American Diabetes Association, and this is a trial as in geographically multivessel coronary artery disease with a severe of 70 or more % lesions in at least 2 major epicardial vessels. The indication for revascularization was either angina or objective evidence of myocardial ischemia. So the exclusion criteria were about those patients who had severe congestive heart failure, patients with simultaneous surgical procedure, a prior CABG or PCI within 6 months, a prior cardiac valve surgery, patients with more than 2 chronic total occlusions in major territories, and patients who have acute ST elevation within 72 hours, and those who have a level of CK more than 2-fold above the normal range, and stroke within 6 months, or stroke of more than 6 months with residual deficit, and patients who were enrolled in another clinical trials. So the targeted hemoglobin A1C in this trial was less than 7%, and the targeted LDL was less than 70 milligrams per deciliters, and the targeted blood pressure was used to be less than 130 over 80 millimeters of mercury. So all of the qualifying angiograms were reviewed by either interventionist and a cardiac surgeon. So in terms of CABG management, the use of an internal memory artery to the left anterior descending was strongly recommended in all patients. The question the decision whether to go for conventional CABG versus a pump CABG was made by the decision. It was like an individual surgeon decision. Regarding the pre-stent process, patients with left main was an absolute exclusion from this study. And for all patients who have been receiving drug-eluting stents, there was only one type, which has been used for all the patients. And those patients were treated medically with aspirin, clopidogrel, anticoagulation, and clopidogrel was discontinued in less than a year. So the myocardial infarction definition for this study, either within the 30 days of the revascularization or after the first 30 days, within 30 days of revascularization, it was defined as the presence of new Q waves or CK elevation of more than 2-folds of the normal range, or with elevation of CKMB. And after 30 days, it was defined as a typical rise and gradual fall of troponin, or a more rapid rise and fall of the CK-MB, and at least one of the following, either the presence of ischemic or symptoms or atypical ischemic symptoms, presence of Q waves, the presence of ECG changes of ischemia, coronary artery intervention, and pathologic findings of acute myocardial infarction. So also in this trial, the stroke was defined as a focal neurological deficit of central origin lasting more than 72 hours. So basically, in this study, almost around 33,000 patients were screened to be involved in this study. Unfortunately, only 10% out of those 33,000 patients were eligible to be involved in this study. And out of this 10%, only around 60% who were consented and actually involved in this study, around like 1,900 patients. So for those patients, the 1,900 patients who were involved in this study, almost they were similar hemodynamically, clinically, and also in terms of the medications that have been used and the laboratory testing. So now we come to the most important slides of this presentation. So here we are comparing the primary outcome and the two different groups. So here in the horizontal line, we have the 5-year event rate. And on the vertical line, we have the rate of developing death, stroke, and myocardial infarction. So as you can see here, that patient group with PCI had a rate of 26.6%, and people with CABG had a rate of 18.7% of developing death, stroke, and myocardial infarction after almost 5 to 6 years, which shows statistical significance. The second comparison between the two groups is regarding the rate of the myocardial infarction. So almost after a follow-up of 5 years, we have a rate of 13.9% with PCI and regulating stent, and almost around 6% with rate with people who has been treated with CABG, which is also showing a highly statistical significance. Now comparing the two groups according or regarding the all-cause mortality. So people with PCI has a rate of 16.3%, and people with CABG had 10.9% rate of all-cause mortality. So here comparing also the two groups regarding the stroke and stroke, like we have a slightly higher rate with people who underwent CABG or patients who underwent CABG of a rate of 5.2% at the end of the 5 years follow-up. And people who have been treated with PCI, they have a rate of developing stroke of 2.4%. Regarding the repeated revascularization rate after 12 months or after 1 year, patients who have been treated or revascularized with PCI have a rate of 13%, and CABG group with 5%, which is also statistically significant. So the total rate or the MACE rate, comparing the two groups, PCI patient had a rate of 17%, and CABG patient had a rate of 12%. Here, comparing the two groups, the patients who had underwent PCI and those patients who had underwent CABG regarding the syntax score, which is showing the complexity of the coronary artery disease. So we can divide them into 2 or 3 groups, patients with syntax score of 22 or less. And here we have the event rate for patients who had underwent revascularization with PCI. They had a rate of 23.2, and people with CABG of 17.2%. And syntax score of 23 to 30. PCI patient had a rate of event of 27.2. And CABG patient had a rate of 17.7 after a follow-up with and a duration of 5 years. And regarding the syntax score of 33 and more, like more complex coronary artery disease, after 5 years of follow-up, PCI patient had a rate of 30.6% rate of developing the event. And people with CABG had a rate of 22.8%. So what we can realize from this picture is that PCI almost were worse than CABG in all the prospective subgroups, and all the variables were in favor for CABG as a revascularization technique to be followed. So in conclusion, in patients with diabetes and advanced coronary disease, CABG was of significant benefit as compared to PCI. Myocardial infarction and all-cause mortality were independently decreased, while stroke was slightly increased without a statistical significance. There was no significant interaction between the treatment effect of CABG on the primary endpoint according to syntax score or any other pre-specified subgroup. CABG surgery is the preferred method of revascularization for patients with diabetes and multivessel coronary artery disease. So there were slight limitations for this study. So as you have heard that on a long-term disease, this is a relatively short-term study, only a follow-up of like maximally 7 years with a minimum of 2 years and a median of 3.8 years. Longer-term follow-up of freedom will lead to better understanding of the comparative benefits by CABG specifically on mortality. So regarding the cost effectiveness, the total cost for index hospitalization of CABG was almost $8,600 higher per patient compared to PCI. And over the next 5 years of follow-up, costs were higher for PCI, mostly due to repeat revascularization. But cumulative 5-year costs remained almost $3,600 higher per patient with CABG. Model expanding results over lifetime, CABG more economically attractive compared to drug-eluting stent with PCI, driven mostly by an increase in survival. So as you can see here in this picture, that here's the cumulative cost, and this is the annual. Comparing the CABG with the PCI, the first year CABG was more costly than PCI, but with increasing in years with the follow-up, PCI has increased and the cost in comparison to the CABG. And as I said, the cumulative cost was higher with the $3,641 for CABG. So analyzing the freedom trial, we would analyze first the question. It was an important question to be raised, though it was not new. It has provided quality data and it was added to the evidence base. And also the design was randomized, multi-center superiority and cooperative effectiveness, comparing the PCI group with the CABG. The sample size was like almost 85% power at a two-sided alpha level, 0.05 relative reduction, an event rate of 18%. The endpoints, primary outcome, composite all-cause mortality, and non-fatal infarction and stroke at minimum 2 years. And the conclusion was the primary endpoint supported by data. And for those patients who have been involved, like almost 80% had a triple vessel disease, lifting like almost 20% for patients with double vessel disease. Applicability, I think it's potential change. It would create potential change in the clinical practice favoring CABG than PCI. So the results of freedom to the consistent evidence base supporting CABG as the preferred strategy for patients with diabetes and multivessel coronary artery disease. It will be important to determine whether the relationship between the primary endpoint curves is maintained with longer follow-up. If we consider the failure of the saphenous veins, whether the continual evolution of new drug-eluting stent technology will diminish the advantage of CABG is unclear, but appears less likely if CABG protects the myocardium against immune disease. And reaching to the end, thank you.
So any question or comment for Fatima?
I have a question.
Yes, Doctor.
So my question to Fatma is that first, it's a good summarization of this trial. there are a few things that I'd like to ask about the interpretation, your personal interpretation of the graph that you showed it near the end. Can you please show that again? Is Fatma still with us?
Yes, doctor. I just need a second, please. Can you see the slides, doctor?
No, we can't.
Mm.
We can see.
Okay.
So if you go toward the end, please. Okay, the one before, after that.
Okay. Yes.
Okay, you made a comment about this slide. Do you recall what did you say?
Yeah. For me, I think that like PCI has like worse than CABG in all the prospective subgroups, like groups with syntax and groups with which were divided the patient according to their gender, race, and like the complexity in left ventricular ejection fraction. So I think that with each like group, all the variables have the same favorable result with CABG.
Can you put it on a presentation form, please?
Yes.
Okay, so can you tell me what's the effect of gender on the outcome?
So regarding the rate for the males, like almost we have included 1,000 and 1,300 male patients and 544 female. For the rates for the males, like it was almost with PCI 27. Developing the events, and 18% with CABG, so 27% with more weighted like outcomes higher for the PCI and male group, and also for the 26% higher for female than 21 with the CABG group.
So your interpretation of the effect of gender, female gender on the outcome?
Female. Actually, I'm not sure about like the difference, but I think like in both the genders, like male and female, there was like an increased rate at developing the events with PCI versus CABG.
Okay, so once you see this, the message in this graph, interpreting this kind of graph is that if you see the line crosses the number 1 there, it means it's insignificant difference. So it's CABG and PCI for females is all the same. And the same applies to two-vessel disease, for example. The same applies for if the LAD is not involved. There's no difference between PCI and CABG. And the same applies to, what is that? I can't read it from here.
American side and non-American.
Renal insufficiency, for example. The LV function less than 40, the race if it was looked at, and so forth. Basically, you have to realize that most of the factors that were looked at independently, where there's no difference, but collectively, if you look at the whole study and you collect all the data for everything, yes, there is a difference that PCI is worse. But if you look at it critically, one by one, then you'll find only few of those are of significance.
Yeah, like the hemoglobin A1C level, I think, is that what you mean, doctor, regarding like those factors?
Okay, the hemoglobin, for example, less than 7 did not make a difference. The other one, I'm not sure if the line crosses, but it looks like it just barely touches. So if it touched the line, that's it. It's insignificant. Okay, but look at the other ones that give you really clear things. For example, let's start from the top there. The one that's, for example, the Syntax score 23 to 32. It's definitely better to go for surgery for this group. Okay, and if you have a male, you'll be inclined with males to go for surgery. If you have an LAD involved, it's better to go for surgery. And if you have renal insufficiency, then it really didn't make a difference in those patients between surgery and PCI. The other thing is that they looked at the cost, I think, over only 5 years collectively,
Yeah.
but they did not. But the study went on for 2 years. So with some of the patients living even after beyond that 7 years, and we all actually see that the longer the patient lives, the more cost they have if they undergo the route of PCI. The initial cost, you can see that, which is the cabbage there. But if even with each subsequent intervention, and not all cabbages have frequent intervention after that. I'm not sure why they have those listed there in year 2, year 3, year 4. They're definitely not undergoing redo cabbages for that group. Anyway,
Yes.
Very nice presentation. Interpretation of the data was good. I think you should always make sure that you interpret the graphs accordingly. The conclusion in the next slide after the graphs was also, there were some other things there. Can you go back to, not sure, where is it?
Here?
No, not this graph. I'm talking about the one we were discussing earlier. I can't see. Yeah, after this. Okay, here. Let's see here. Okay. So there are some generalization here made, and of course the study is. There are a few other studies afterward that have delineated, in particular. Hello?
Yes, doctor.
I just lost the slide, and I had some incoming call from the US, so I have to leave. Sorry for that, but good presentation. Thank you.
Thank you.
Okay, thank you very much, Fatma, for the presentation and for the just a comment before leaving the session. For the second-year residents, we are preparing a new schedule for the journal club, so expect a call from us so you will be assigned for a journal club as well. Thank you.